A 45-year-old male presents with a painless, slowly enlarging palpable mass in the hand. I am showing you an AP radiograph and axial T1, coronal T1, and sagittal fat saturated T2 magnetic resonance images. Please describe the findings.
The radiograph demonstrates a well-defined, ovoid soft tissue lucency. The T1 magnetic resonance images show a well-circumscribed soft tissue mass with homogeneous high signal intensity, which demonstrates complete, uniform signal suppression on the fat-saturated T2 sequence.
What is your primary diagnosis?
The findings of a well-defined soft tissue mass composed entirely of fat signal that suppresses completely on fat-saturated sequences are diagnostic of a benign lipoma.
What is the typical composition of a benign lipoma, and what minor features can be present without indicating malignancy?
Benign lipomas are composed of mature adipose tissue. They can contain thin septations less than 2 millimeters in thickness or small calcifications, which are benign features.
How does the magnetic resonance imaging appearance of an intramuscular lipoma differ from a simple subcutaneous lipoma? And why can this be misleading?
Intramuscular lipomas often interdigitate between muscle fibers, giving them an infiltrative margin. This can be misleading as it mimics a malignant tumor, but they are benign if they show normal fat signal without thick septae or nodular components.
What primary malignant lipomatous tumor must be differentiated from a benign lipoma? And what magnetic resonance imaging features raise concern for malignancy?
Atypical lipomatous tumor, or well-differentiated liposarcoma, must be ruled out. Magnetic resonance imaging features raising concern include a size larger than 10 centimeters, septations thicker than 2 millimeters, nodular non-fatty enhancement, or less than 75% fat content.
What cytogenetic molecular test is used pathologically to differentiate a benign lipoma from a well-differentiated liposarcoma?
Fluorescence in situ hybridization is performed to assess for MDM2 gene amplification, which is present in atypical lipomatous tumors and well-differentiated liposarcomas, but absent in benign lipomas.
What is the clinical prognosis for a subcutaneous atypical lipomatous tumor of the extremities compared to a retroperitoneal, well-differentiated liposarcoma?
Extremity atypical lipomatous tumors have an excellent prognosis because they do not metastasize and can be cured with wide local excision. Retroperitoneal lesions are histologically identical, but have a poor prognosis due to a high rate of local recurrence and inability to achieve clear surgical margins.
Finally, what are your clinical management recommendations?
Asymptomatic subcutaneous lipomas can be observed. If the lesion is painful, causes mechanical restriction, or shows features suspicious for well-differentiated liposarcoma, I recommend surgical excision.